Thursday, January 23rd. And this morning, we're doing some budget adjustment presentations from, and we're starting with Dr. Levine from Department of Health.
Great. Thanks for inviting me to testify on the governor's budget adjustment. And I am Dr. Mark Levine, Commissioner of Health. I'm joined by members of my financial team, and Paul Daly is leaving control of the slides, but which I have to actually turn around to see. So if we could, we'll just give you a little orientation, because anytime we appear before any committee, we obviously we have three appropriations in our budget. One is administration and support, one is public health, and one is substance use. And it turns out each one of those is impacted in some small way by BAA.
Can I take one moment to remind the committee of something? The Department of Health, I know that there are a couple things in budget adjustment that, you know, is sort of the purview of committee, but I want to remind everyone that substance use is in human services. So we won't be asked to make recommendations to appropriations on that piece. But thank you. Go ahead.
You know, I'll point out also that the way the Agency of Human Services is working in recent and current year is so much is across departments. So even though each budget is being presented independently, there's so much crosswork going on across the agency. Do they have the agency's ups and downs? Yeah, so this is not something this committee usually gets into great detail on, but if you need to, pages 9 and 10 are where the department appropriations are. So starting with our administration and support appropriation, this is the one of least major consequence. It has to do with requesting additional funding for the cost of the health department's share of the agency's service level agreement with the Agency of Digital Services. So there's a total up there of $646,940, which is the difference between what was budgeted and the fiscal year 2025 has passed. So you'll see that in every part of the agency's testimony as each department has got its share that it's going to put up there. Not one to get super excited about. Moving into the public health appropriation, that one's a little more interesting. This one is to request $100,000 general fund for a grant to Planned Parenthood of Northern New England for women's health care medications. The medications are a one-year stock of 2 medications that are used for medical abortions, mifepristone and misoprostol. And this will help assure uninterrupted care, uninterrupted access to care for patients in Vermont. This is, as some of us were talking earlier, a bit of a disruptive, chaotic time based on previous experience. When we did the same thing a number of years ago, it may be important for them to have a supply on hand. Medications that might be hard to get in the future.
I have a couple of questions about this, but does anyone else have? Go ahead.
So this allocation goes to Planned Parenthood. Does it get distributed to anyone else providing this care, or just Planned Parenthood?
This is going to Planned Parenthood, but what we've done when we've surveyed and inventoried across the state previously is the majority of this type of abortion, a medication abortion, is done there. Even the academic medical center, 80 to 90% of what they do is more surgical. And these medications are really meant for those who don't need to have that level of care. So most hospitals in the state will have enough of a supply to get by. But the reality is Planned Parenthood needs a much larger.
And they will be aware that they could get backfilled from Planned Parenthood if they need, if their supply dwindle.
I'm pretty sure they will be aware, but I don't think it'll be a
An issue.
huge
Yeah,
issue,
this is
to be
fine.
honest.
Thank you.
I apologize, because that was actually one of my questions.
Mhm.
And I missed the very beginning of your answer. I was just wondering, does Planned Parenthood plan to hold the medications, and will it be available to other providers? If they request it from Planned Parenthood, if they need it or no?
Oh, I guess I don't want to answer for them because my sense is they won't get these requests. Hospitals have their supply chains and they inventory what they have and know what they need. I would hope in the spirit of we need to help everyone and somebody needs some doses, we should be able to transfer those, but I can't speak for them. But I think they would probably have that understanding because when we entered into this previously, we kind of looked at it as what is the state's supply of this medication and where were we comfortable, where were we uncomfortable with that supply lasting or being threatened if there was an importation ban, because a lot of this medication comes from Ireland, it turns out. Or if there was a new Supreme Court case, about the FDA's ability to approve these drugs.
Are these drugs used for other?
There is a slight use of some gastrointestinal disorders. I would say it's so minimal at this point that this is the major use for these drugs. But there are other uses.
For things like ectopic pregnancies or?
It depends. It depends. Generally, if, an ectopic, you would have to deal with locally where it is surgically, as opposed to expect this drug to be effective. But I don't want to. Its major use would be,
My other question is, how much does 100,000 buy? What is that?
So last
What
time,
kind of supply does that buy?
when we looked at the costs previously, it was in the $40 to $50 range for a dose. You don't remember? Yeah, I remember. It was in the $40, $50 range for a dose.
How many doses?
Well,
100,000
Right.
by
2,000.
2,000. So thank you for doing the math.
Yeah, which is actually a number we thought of. I'm pretty sure.
And what's the expiration date on it?
It has so one of the drugs has a 2-year life term, so lifespan. So that's of a concern because a previous stockpile might not last long enough to help during this period of time.
Okay.
That's pretty unusual, 2 years. Most drugs, people can use them for years. 2 years is a narrow window.
Woody, let me go to Woody first and then Hopper.
Is it an oral?
Yes.
And is this due to an influx of individuals from outside?
So it turns out, this is not due to an influx. Do we anticipate there will be more than just Vermonters getting this because people come from Louisiana to have this procedure? Sure, but I don't think the numbers support that there's been like a huge migration in. So I wouldn't expect it's going to be huge numbers. We are surrounded by states that people don't have to travel from generally. And so I can understand a person in the deep South not having as many options. There probably are still closer options than Vermont.
Last year, last budget session, was this line item in there?
Not last year,
It wasn't. Okay,
23.
It's not been in our base budget at all, sir. Representative McFall, this is a one-time appropriation, and we don't routinely receive an appropriation to provide assistance for these kind of purchases to this organization.
So this is new.
It's a one-time, and with our, I hesitate, but it's not the first time that the state has offered this assistance. There was a similar purchase award 2 years ago.
Yeah.
April 23, when the Supreme Court was hearing
Yeah,
a
yeah.
case that would ban one of the medications.
And was it the same amount?
In that case, it was a larger amount and it was a 2-year supply.
Okay, thank you.
Leslie, I do see you,
All
but
set.
can I, okay. You mentioned, a ban on importation. I was wondering if maybe you wanted to just talk about Comstock a little bit. I think that's what you might be referring to for education or for the committee. What you mean by a ban on importation?
Yeah, so depending on the status of reproductive health, based on whatever, executive orders, legislation at the congressional level, what have you, it could be more challenging for drugs like this to either come into the country, or I think what Comstock refers to as, or to have mail order ordering of these drugs and cross state lines where the prescriber is in one state and the user is in another state. So I don't want to go beyond my medical expertise into the legal realm, but these are concerns that everyone has. Access to the medications, access to abortion in general, and what is the status of reproductive health and freedoms for that in the country.
All right, thank you. Any other questions on this line item? Okay,
We will still show you the substance use appropriation, which is the administration's requesting just over $1 million additional funding for substance misuse prevention programming. So we're very proud that the legislature and governor a number of years ago agreed to steady annual influx of money for prevention programming coming from the state. So under the current law, 30% of the year-end balance in the Cannabis Regulation Fund shall be allocated for substance misuse prevention services. When the fiscal year 25 budget was passed, it included $3 million in the substance use program appropriation for this purpose, which is the amount that has gone year to year for this purpose. The fiscal 24 year-end transfer was greater than estimated, and the 30% earmark for substance misuse programs totaled $4,025,125. So we will use this additional funding to continue what's been happening on a year-to-year basis, which is expanding long-term, statewide, school and community level evidence-based strategies to prevent substance misuse. So providing education, positive alternatives, policy changes, community support, early identification of problems, and referral to services is how all of these prevention programs work to help Vermonters of all ages, but especially our youth, lead healthy lives. The General Assembly had a very far-sighted decision to dedicate a part of the cannabis tax revenue to this. And this gives us a chance to really do more of the scaling and sustainability of these programs. We've always had the chief concern about geographic equity and making sure that we weren't just serving one region of the state, one community here, one community there, but could make this scaled appropriately. And this will allow that and allow them to be sustained to ensure success. So beginning in fiscal year 26, the law directs 30% of cannabis excise tax revenue for substance misuse prevention programming, up to a maximum of $10 million a year. So we will continue to expand prevention programming to that level as the revenue allows. And this is what is in the budget adjustment to accommodate this first year.
Our sales were more than we anticipated. Is that?
It's a
what we're-
thriving market.
Okay.
Yes, look at that any way you'd like.
Davey?
Thank you for all the work that VDH is doing in this space. I don't know if you remember, I used to sit on your
Yes.
oversight committee. And I focus very much on mental health in this committee.
Yep.
And I'm greatly concerned that we are not doing enough in this state to look at mental health and substance use together and prepare our workforce to treat co-occurring disorders. Can you talk a little bit about how these funds, if any of them, are used to prepare our workforce to look at co-occurring disorders?
I'll have a lot more to say about that after the budget address.
Great.
With regard to these funds, I have to be honest, they are much more substance misuse directed, but the same community organizations and school personnel and others who are addressing these problems are still the trusted community for our youth and are certainly going to be aware and attuned to the co-occurring issues. With our youth risk behavior survey, we see every year these significant rates of youth who say they have anxiety, they have depression, they may have thought about suicide, they may have actually attempted suicide, et cetera, et cetera. So we see that whole spectrum, and it coexists, as you're correct, with issues of how do we youth treat their anxiety and the stress and the pressures they're under. Are they starting to vape? Are they starting to use alcohol? Are they part of the thriving cannabis market, even though they can't themselves purchase in a dispensary? So, these are the statistics we keep all the time. So you can't deny that the problems are interrelated. There are separate mental health initiatives, of course, that are going on as well in the area of rapid access to care, urgent care programs, crisis teams, activities that I think sort of allow youth to have a trusted sort of listening person. We're also very concerned about the kinds of YRBS data that show that a little over half of our youth say that they feel like they matter to their community. I look at that as the glass half empty, not the glass half full, because that means almost half don't think that. And when you ask them, do they have an adult, outside of their home that they can talk to, the numbers also, they're not quite as high as that, but they don't see that they have that individual that they can trust as well. So these are the kinds of things we're trying to do. So they do cross over both substance use and mental health. There's no question about it. There's a lot of debate about what is the statistical rate of people who share both disorders. And some say it's as high as 70+%. Others are 50%, others are less. I'm in the group that believes it's higher, not lower. But the reality is, as long as we're addressing all of them, I don't think we need to argue about the number. We need to just make sure we have programs that are responsive to them both. A lot of our health department funding comes from SAMHSA. And SAMHSA, as you know, if you break down the acronym, it's mental health and substance abuse. So you can't separate the two ever, even if it doesn't look like on paper they're being integrated together.
Thank you. Any questions on this area?
We actually have two other one-time appropriations. First item is an increase of $150,000 general fund for the legislatively directed household health insurance survey. Something I've talked about in previous years. This is the year that things are happening, and we actually contract through a competitive bidding process to have this survey done. And the final contract cost is $550,000. So we need an increase of $150,000 in our BA.
Is Is that in the field right now? Is
Yes.
that surveys going on right now?
This is the year. It's supposed to be a sort of an every 3-year thing.
Okay,
This is when it's.
are we using the same contractor for this that we have in the past?
I will ask my financial director that question.
Chairman, sorry, I don't. Contractor comparison. The survey itself is very similar to the one that was used 3 years ago. That was designed to make sure that the results would be comparable.
Okay. All right,
And there'll probably be a report late spring.
That was just me.
I love that report, so
Yeah,
just,
that's a really.
if you think people aren't reading it, I don't know.
No, I know people.
Yeah.
We are.
Yeah.
It's really
It
vital.
will be especially timely this year because of healthcare reform and what's happening with
We
the Fed
make
and
a
all.
lot of decisions around
Right.
information that comes from that, so.
Yes.
I can't speak for the rest of the committee, but I'm happy to.
I ask,
Yes, of course.
just, because I'm new and I don't know, what does the survey mean? What is the?
Oh, so it tells what percentage of Vermonters are insured for health, what percentage have no insurance, uninsured, and also gives us insight into, I think, the most important category, which is underinsured. So on paper, they have insurance, but what does that actually mean if they develop a symptom or an illness or what have you? And so we can compare those directly to each previous survey to get a sort of
Okay, thank you.
trend line, if you will. There's also demographic data within that about each of these groups.
I got called, it was fun.
3 years ago, I got it. I was thrilled when I got it. I'm like, oh, I was chosen.
Just like, hey.
All right, thank you.
And then there's one left.
Okay,
This is a one-time appropriation again for $500,000 general fund for community grants related to health equity. In the fiscal year one-time budget, the General Assembly did appropriate base funding of an Office of Health Equity, along with funding for the community grants we're going to talk about, to the Agency of Administration. But the administration has opted to establish the Office of Health Equity in the Department of Health. So this is to transfer on a one-time basis, this money from agency administration to Department of Health.
so this is just a transfer.
Yes, the money's.
Can you explain what that means? What happens with this money? What?
Yeah, so these are grants to community partners through an RFP type of process to allow worthy projects that advance health equity to be funded. No, they're pretty modest in individually, but in aggregate, you get to $500,000 pretty quickly.
So an example of what would happen when these funds are spent during COVID.
Yes,
Certain populations were not.
exactly. They weren't able to have the same access to testing, vaccination,
Yeah, okay, so that's what they're.
messaging and medical information about what they should be doing, all of that. That's a great example. That predates all of this and probably catalyzed all of this. It was probably the most powerful catalyst.
Thank you.
Daisy?
I apologize for putting you on the spot, but I feel like it's an important
But that's
question.
what this chair is all about.
Right now, I'm hearing from a lot of residents about, and myself, just concerned about changes happening in our country and in our state.
Yes.
I wonder if you have any message to Vermonters who are concerned about continuity of reproductive care, gender affirming care. What's your message about concerns that we have about being able to assure residents of Vermont that we can continue to support those things for them?
Yeah, I have to make it a very careful message because they had to overreach our boundaries. There are things that can happen at a federal level that I can't predict nor just calm people down about. But I can say that at a state level, this body has enshrined the right to abortion in the Vermont Constitution. That's pretty powerful. And that says a lot about reproductive freedom and reproductive health values in the state. We have active clinicians who are still seeing patients who have gender issues, and they need gender affirming care, as it's called. And there's no interference with that as of today. But again, I can't just assuage people's fears about the future. I can say what I do when people ask me about my department and the threats to my department, and are we going to be able to do all the things we do all the time? And yes, there are some areas we're especially focused on, like reproductive health, because we know those are very significant hot ticket items potentially. And you saw the appropriation that we have in there. But we can't react to everything that way. And we also can't overreact without actually seeing what happens and get our work done. And so the message to my team has been, we maintain our values, we maintain the work that we do and the good work that we're also proud of, and we should continue to do all that work. And we can't possibly keep distracting ourselves with every executive order, every, speech to the base, every whatever, because it'll just be an insane environment and we won't get productive work done that we could still be doing. So that's sort of how I frame it. Try to be reality-based. I also don't want people to think, well, he has his head in the sand. He's not going to be able to react appropriately. We've already looked at our budget and where the threats are and thought about these things. But to go further than that right now, there just too many things we'd have to do that, and it would distract the whole department from getting the work that it should be doing.
Thank you. Any other questions? Oh, Leslie?
So, the state, of course, is divided into HSAs, and I come
Yes.
from the southern part of the state.
Yeah.
We recently lost primary care in Bellows Falls, so we're now primary care
Right.
desert. And I'm just wondering how you, through your HSA, or do you
Mhm.
think about access to primary care, and how do you work in that space?
Yeah, no, we think about that all the time. We are not the part of the agency that can do as much policy-wise or focus on that, but we collect data on that. We do a state health assessment that looks at rurality and geography as factors potentially and health outcomes. We probably within the next 6 months will release our latest state health improvement plan. And through doing and that comes from our state health assessment. So it involves government sectors, agencies, agency departments, and partners all around the state and Vermonters themselves. And they've already told us in the state health assessment that access to care is one of their top 4 or 5 concerns. So we will be addressing it for sure.
Are you in a position to say how or where in?
That's the work we're doing
That's
in
what
these
you're
6
working on
months.
now. Okay, so that's what we'll see in the improvement plan.
Yes,
Okay, got it. And you said it's another agent, others in your agent in the AHS world.
Yes.
So can you say who that might be?
well, I mean, we've got a director of healthcare reform, and everything about AHEAD is trying to preserve primary care
Mhm.
and nurture it.
Mhm.
Because it's, as a primary care clinician, it is a field that is not having tremendous uptake by medical students. So
For obvious reasons.
we just have to deal with that. Fortunately, there are other healthcare providers like physician assistants, nurse practitioners, et cetera, But even there, it's not like you can just rely on that to be your entire primary care contingent across the state. Other parts of the agency obviously are DEVA, and Medicaid, and the parts of the agency that take care of special populations, whether it's Dale and worried about, do we have enough care for our older Vermonters? Well, we're certainly not going to be geriatricians because there's a national shortage of that, but at least every older Vermonter needs a primary care clinician. So everybody in the agency is worried in some way about making sure that access to care is something we address.
So if I may.
Yeah.
I think the governor and signed
Yeah.
off on ahead, but for cohort 2, and then there's no ACO, so I'm worried about this gap.
This gap year,
Yeah, so could you
26.
help me not worry?
Yeah, so I can't give you false not worry, except that, because the signatures just went on the page Friday, it's not like everyone's had a chance to develop a plan. But we know the threats, and the threats are in terms of making sure that the primary care contingent does remain robust. There are going to be new demands on that contingent in terms of incentive payments from the federal government that they didn't have to worry about administratively before. Programs like MIPS, that acronym rings a bell here.
I've heard about it, but I don't know what it stands for.
Medicare incentive payment, something.
Okay, that's helpful. I've heard.
And so, OneCare took care of a lot of that. So questions about how they can or can't help, continue that. There's concerns about the blueprint and SASH programs. So everybody's aware of these things. None of them has been, the sky has fallen. It's just, these are where the threats are and things we have to think about. And we have until 26, till that moment when reality hits.
Yeah,
Because the head would start in 27,
right.
and we're good through 25
Right.
with the all payer model. So that's the year 26. So there is time, but it's not like it's not on people's radar screens.
So, and you may not be ready to talk about this, but I'm just wondering what preparation is in play for 26 in primary care.
Yeah,
Yeah.
yeah. So
And I get it.
yeah, so,
You're
so
working on it.
I'm only a piece of
Yeah,
being able to answer that.
Yeah.
There are others who actually have to focus on it much more.
yeah.
Tucker?
Doctor, I don't know whether you're the person to ask about this or not, but we've put money into a program so that nurses and doctors, we can help them with loan payments and stuff like that.
Yeah.
Do you have any idea how many doctors, primary care doctors are in that program now?
We can get you that information. I can't believe any of us can give you off the top of our head, but yes. I can also state quite candidly, though, that we're not the only state that does that. Every state, not every state, but most states are thoughtful about this and trying to do that.
Yeah.
I'm not sure there's a lot of data out there about the efficacy of that.
Yeah.
And is that really getting us what we want?
Yeah.
Either
That's-
upfront or in a sustained way.
Yeah.
But that's just the reality.
Okay.
I think I'll take the opportunity to ask the question because we don't have the pleasure of your company very often. I know you're here for budget adjustment, but as you know that the legislature enacted some laws around safe storage or negligent storage of firearms.
Yes.
And I would be remiss if I didn't ask you, what is the Department of Health doing to ensure that Vermonters know about this and, because I believe injury prevention is in your purview.
It is, no, it's very important. And I dare say Stephanie Bush has been on television more than myself in the last few months. One of the areas that she's actually talked about with media, and we have a lot on our website on, and we've actually gone across the state with, is this whole notion of safe storage, what's available. what Vermonters don't actually have to pay for because we can provide for them what we have.
What do we provide?
So these locking devices,
Mhm.
if you put your guns in a specific storage area, that they will be locked. We provide the counseling about what safe storage means, because it's not just the storage, it's also the separation of ammunition from what you're storing. So all of that really has been, I think, I don't want to say it's overwhelmed the news headlines, but it's certainly been out there, and we've done a lot. We've given a grand round series in concert with the Department of Veteran Affairs, because that's a very high-risk population, especially for firearm suicide, which, as we all know, is unfortunately a more successful way to attempt suicide. And that population, we've been very concerned about. And they are actually, we've gone to every hospital in the state essentially with a grand rounds kind of presentation that includes this whole component of it in a very practical way, not just sort of here's the statistics, but here's how we work in Vermont to counter suicide. All the suicide programs we have, 988, Facing Vermont website, which is a fantastic website if you haven't gone to it, and obviously the crisis lines and things of that sort. So we're doing what we can to get the word out on those things, and hopefully we're making an impact. Not sure, we can ask Stephanie if she has some data about how many we've given out. Because that's, it's great to talk about safe storage, but you actually want to know that it happens.
Mhm.
And the biggest impediment for it to happen is at the time of a purchase of a firearm, if you don't get what you need right then and there, it's like, oh, I need to get that. Oh, I'll figure out when I can do that. And it never happens. It's kind of like if you got your COVID shot, and you didn't want to get your flu shot that day, and I'll get it in a month or two, and then you never get your flu shot. So the more we can do right there and then, the better.
Great. Thank you, and thank you for the work that you do on behalf of Vermonters, and thank you for coming in.
Thank you so much.
Okay.
So we're gonna take a break until 10 o'clock when you're gonna hear from Department of Vermont